Welcome to this masterclass on COPD management. I'm Dr. Beena Sajith, and today we're discussing the logical escalation of therapy. COPD management isn't a guessing game, it's a strategic roadmap based on clinical evidence and patient response. We start with the foundation: maintenance therapies like LAMA and LABA to improve airflow and reduce daily symptoms. Long-acting muscarinic antagonists and beta agonists are essential for bronchodilation and symptom control. But when do we move up the ladder? The moment maintenance alone is insufficient to prevent exacerbations. Escalation is triggered by persistent dyspnea or frequent respiratory flares despite adherence to initial therapy. At this stage, we often introduce inhaled corticosteroids, or ICS, particularly in patients with high eosinophil counts. ICS works by reducing airway inflammation, which is key for those at high risk of frequent hospitalizations. It's a delicate balance. We must identify patients who truly benefit from ICS to avoid unnecessary side effects. Risk factors like pneumonia must be weighed against the benefits of anti-inflammatory therapy. As the disease progresses, some patients will require supplemental oxygen therapy to maintain blood saturation levels. We assess hypoxemia through arterial blood gas or pulse oximetry to determine the need for home oxygen. Long-term oxygen therapy has been shown to improve survival in patients with severe resting hypoxemia. When chronic management fails, acute exacerbations may necessitate a transition to more intensive interventions. In acute hospital settings, IV corticosteroids become a primary tool to rapidly resolve severe airway obstruction. Intravenous delivery provides the potent systemic response needed when inhaled therapies are no longer effective. This clinical ladder, from bronchodilators to systemic steroids, is our roadmap for managing this complex disease. A common question is, when do eosinophils dictate therapy? Generally, a count above 300 strongly suggests ICS benefit. Eosinophils serve as a biomarker for type 2 inflammation, guiding our decision to add steroids to the regimen. Another student asks about recurrent exacerbations. If flares continue on triple therapy, we look for other phenotypes. Managing recurrent flares requires a holistic view, including pulmonary rehab and addressing comorbidities. The goal is always the same: reduce the burden of symptoms and minimize the frequency of life-threatening events. Logical escalation ensures that every patient receives the right intervention at the precise clinical moment they need it. Thank you for joining this masterclass. I hope this provides a clear roadmap for your clinical COPD management. For more medical insights and professional resources, stay tuned. I'm Dr. Beena Sajith.